The next presenter is Dr. Joseph Saba, who's going to be presenting on the Gardasil Access Program, lessons learned from a public-private partnership. Dr. Joseph Saba is the co-founder and president of Axios. He is a Lebanese and French medical doctor specializing in infectious diseases with extensive experience in research, health management, and access to medicine. Before he started with Axios, he previously worked with the World Health Organization as the WHO focal point for the National Plan for HIV Vaccine Development. He is well known internationally for establishing one of the first HIV/AIDS antiretroviral drug access program in Chile, Cote d'Ivoire, Uganda, and Vietnam through the UNAIDS HIV Drug Access Initiative. Under his leadership, over the last 15 years, Axios has launched a range of global drug access programs and developed innovative models for health system strengthening across multiple disease areas, including HIV/AIDS, oncology, and other chronic diseases.
Thank you, Ricky. So I want to talk to you about one of the experiences that Scott alluded to related to having a number of programs that are starting without having the solid, I would say, pilot framework that is needed. Today I will talk, this is the Gardasil Access Program. I'll talk about the update and the lessons learned, how we move forward with it, and how we can apply the lessons learned. So basically what happened is this is the Gardasil Access Program. It is a donation from Merck, who committed 3 million doses to vaccinate actually girls for 3 million doses. And the way we structure the program is to enable organizations in a number of low-resource countries to be able to come with initiatives to vaccinate girls, and of course with make sure that they have proper logistics systems and sound health programs. But we kept it open, and these institutions in the countries could apply and tell us how many doses they need. Their application is reviewed, and then we can and then they receive the doses, and then of course we follow up with them about what happens. Recently, because Gavi is stepping in actually with these countries, then GAP would have accomplished its purpose. So now we stopped providing these donations, and we're really trying to follow up and consolidate the experience from these countries. So this is a map that shows the countries that have participated, that have basically benefited from these applications. About 1 million doses were shipped to them, and there are 22 institutions in 20 countries, and they received enough to vaccinate about 350,000 girls. For now, not all the 350,000 girls have been vaccinated because the vaccination is still in process. What we're going to look at here is, the primary data that came from 16 actually projects in 11 countries and 200,000 girls. What we try to look at is what we call the vaccination coverage. So it's not exactly the coverage that we use in EPI, but it is more actually looking at what was the target in terms of vaccinating girls, and what are the number of girls who received all 3 doses. And the coverage, the median is 91%, and the average is 90%. So most of these programs have really delivered close to what they expected. And then we looked at the adherence, meaning what among the girls who received the first dose, how many really received the second and the third altogether. And here also we have an average of 92%. That is close to the median as well. We also divided them into 3 models. One is the classical school delivery model. And the second is, we called it mixed, which is health facility based and school delivery model. And then we have the health facility alone. The results are really comparable and pretty good in terms of, about 92%. What's interesting here, I mean, it looks like the health facility delivery model looks better, but in fact, it's only 3 programs. There are very few girls vaccinated, and any change in this will change completely the results. So I wouldn't take it for granted that this is a better model at all. Most of the applicants have really opted for the mixed delivery model with 155,000 girls included in 8 programs. So in a publication that we have actually published a few months ago, the mixed model was probably among the one that delivered most results. But there are more programs that are now continuing, so we'll have more data about it from another 18, 18 programs that will be able to deliver. This is the list of the programs. You could see some, like especially for the health facility-based, very few girls and small programs. Most of the doses that were delivered with the mixed delivery model. That was, interesting. We also looked at, and here we're looking more at the programmatic aspects related to coverage and adherence, and saying, is there any relationship between the number of sites where the vaccine was delivered and actually the coverage and adherence? In terms of coverage, which is the number of girls intended to be vaccinated versus those who have been vaccinated, actually got all 3 doses, there was absolutely no correlation. But it's interesting, and this is an interesting trend that we will need to see if it will continue as we get more data. Is there seem to be a correlation between the adherence and the number of sites, meaning the more there are sites where girls are vaccinated, the more the adherence. As long as we stay with small sites and small vaccinations, we get better adherence. So this is the initial trend, and we will see if this is confirmed as we get more data. So another aspect related to the programmatic things is the lessons that actually the institutions have shared with us in terms of challenges or things that they think should be paid attention to when we design a program, or some of the challenges they're faced. One aspect is parent consent is very important, and I think Scott also alluded to. So it's very important, and here the communication, we'll see it later, is key related to that. Also, one of the challenge of the school delivery model is you need to vaccinate within the school year. And if you start a little bit late, then it's hard to give the 3rd dose because it's over 6 months. So here there has been some challenges for that, and it needs to be watched. And that's why the mixed models sometimes were helpful, because when things fell in the holidays, the health facilities took over the vaccination of girls outside the school. The other one is basically some people looked at coupling mother and daughter with cervical screening and vaccination. The human resources, most of speakers talked about the importance of training health workers, and this is important. To provide the counseling role, of course, train them on delivering the vaccine, but also more importantly, to reduce the spread of misinformation. In the beginning, when the health workers were not well informed about the benefits of vaccination, sometimes they spread some misinformation that wasn't great. Also, train the teachers. That has been an interesting experience that people have witnessed, where the teachers were instrumental in getting the girls to be vaccinated and getting all 3 doses. So this is an important aspect. The communication also Scott alluded to earlier, which is the same experience that we have, working with strong communication, making sure that there is a buy-in from the community leaders. That has been instrumental in getting the parents to agree and the girls to be vaccinated. And the other one is, the coast use the existing vaccination campaign. That's also what you mentioned, Scott, which is important. So moving forward, we will have data from an additional 18 projects. Some of them have completed, and some of them are going to complete, and we will be looking then more in depth as we are basically wrapping up this program. We'll be looking more in depth at a number of qualitative and quantitative outcomes, like vaccine delivery strategy, sensitization, the acceptability of the vaccine, the cost as well, and the link to adolescent health and the various delivery aspects. So we'll be looking at the data in terms of consolidation. Now, one of the things I want to share with you here is the interesting aspect of this model from our perspective, which is, not one or the other, but it can go in tandem with very well-structured pilots that provide a good framework to provide golden standards. And actually, during the course of the Gardasil Access program, we worked in a very good collaboration with PATH, who helped us share some material and some of this state-of-the-art knowledge that they have from the pilot program to help our applicant do a better job. So we feel that this model will rely on initiatives from the various countries who want to go for a vaccine, but maybe they have some buy-in from the government, but it's not yet a government policy, and they want to try it. And by doing so, using some private solutions, based on donation, and it's not just donation, get the donation and see what it is, but it's really structured within program that we follow. That creates actually a cascade of experience in the country and creates a momentum that can generate and encourage the government in basically putting it among their priority and start looking into policy aspects. This has been a successful experience in the HPV field. We have done similar experiences, one of them in HIV, in prevention of mother-to-child transmission, where it has created enough momentum before the funding came from PEPFAR for prevention of mother-to-child transmission. Here it would be coming from Gavi. But these approaches all together will help actually build that international momentum to be successful. Thank you very much.